else who needs to make any announcements? Joseph Zalkin from the National Perspective, NMSP, anything on your end that we need to know?
The time is now if you're interested in FAMS credentialing. If you have 3 years of NMSP membership and have worked with your chapter, you may be eligible. Those applications, I think, run through August.
Great. That's great information for people on the call. Okay. Thank you for that. And all right, so we're having a lot of people coming on at this point in time, so let's get started. Angus, thanks for recording. So we're very privileged to have Dr. Amit Shah come on today. How did I find out about Dr. Shah? There's a big conference that was held out in Vegas this year where a few people called me up afterwards and they're like, there's some great presentations and some great ideas and products that are out there. And someone connected me with Dr. Shah and said, you have to see what they're doing. So I reached out to him, of course, over social media, and he was gracious enough to oblige. So as you can see from his slide, he's the Chief Medical Officer for Innovital Systems and CLR Medical. He's also an emergency physician at MedStar Washington Hospital Center. So Dr. Shah, thank you so much for joining us. If you want to fill in a little bit more of your introduction in case I missed some parts, and then take it away. We greatly appreciate you coming on.
Sure. Thank you so much for having me, Peter. It's a privilege to present to this group. Can you guys hear me okay? I just want to make sure that the audio and visual are coming across clearly.
Yes. Yes, we can.
Fantastic. Okay. Yeah, I've been at Washington Hospital Center in DC, which is level 1 trauma and burn for the last 15 years, and been involved in medical device development for about 8 or 9 years now, and want to talk to you about one of the products that we've developed, which is called a Thorasite. We developed it for lateral thoracostomy. And a quick disclaimer, I'm co-founder and chief medical officer at Innovital, and we're the company that designed the device and then licensed it to Sam Medical, where it's available for purchase. So yeah, let's jump in. So this is the general outline for the talk. I'll start with the problem statement. What is the data that informs us as to how big the problem is, what the problem is? We'll talk a little bit about how we designed the device to address that problem. What's the data behind the device design? I'll review how the device is used, describe the data that supports its use, describe some ongoing studies, and then pause for a question and answer. But I'll ask that at any point, if anyone has a question, please just shout out. It's a little bit difficult in this format to see people and to read faces like you would in an actual meeting. So please just shout out and stop me at any point if you have a question, criticism, opinion, what have you. I want this to be interactive. So starting with the problem statement. So if you look at studies back almost 20 years, since 2005, and these studies include prospective studies in the civilian and military medical world, observational studies, including standardized patients, where imaging is used, cadaveric studies. I think that it's pretty clear that the majority of decompression needles are misplaced. Okay, now that doesn't mean that every one of those misplaced needles causes an injury, but every one of those misplaced needles places a patient at risk for an injury. And I'll review some of this data. And again, at the end of the talk, I'll have a list of references. I'm happy to share all these papers. Again, these are all in the peer-reviewed PubMed world. So anterior needles are almost universally medial to the midclavicular line, threatening the heart, mediastinum, great vessels. Lateral, the site for lateral needle decompression is very often identified below the 6th intercostal space, which threatens abdominal contents. Here we have in this image a needle in the liver. I'm sorry, is there a question? Okay. What's at risk? The structures that are at risk, of course, heart, great vessels, the intra-abdominal contents, and of course, a needle that's misplaced is unlikely to vent the pleural space and address the problem for which you're placing the needle, tension pneumo. This is another published case study, an interesting one, a 22-year-old woman who's involved in a motor vehicle collision. No right-sided breath sounds were appreciated, so an anterior needle decompression was attempted. Unfortunately, it was placed in the fourth intercostal space peristernally, resulting in an RV puncture. The patient arrested and ultimately had a 28-day ICU stay, was discharged to a rehab facility with bilateral vision loss. So not a good outcome, and all due to a misplaced needle. And just so you don't think that this is a problem that was sort of in the past and not a current issue, here are 4 studies published in the last 12 months. And they look at sort of a variety of different metrics, but many of them are using imaging to evaluate the needle placement of pre-hospital placed needles. So the top one shows only 27% of the needles were placed ended up in the right place. A handful of needles ended up in spleen, liver, otherwise intra-abdominal or in the anterior mediastinum. These other papers also are citing in the 20 percentile, 20% approximate range in terms of appropriately placed needles. The last one, which used standardized patient models, and the 60% range for lateral needle decompression. So not great results in terms of accuracy. Why are these mistakes made? I think the real question is, how are they ever placed correctly? I mean, it's such a difficult scenario to appreciate. There's a rush to address a decompensating patient. You've got challenging environments, poor lighting, distractions, a whole host of different body types. Patient positioning is not necessarily going to be optimal, and the providers themselves may not be experienced in performing the procedure. Now, when you add to that the advent of longer and larger bore needles, this makes appropriate needle siting even more critical. So it's a challenge, and I think, and have thought now for some time, that it was a problem worth addressing, especially if we could design a solution that was simple. So that takes us to the Thorasite. Do you guys have any questions so far about the problem or the data?
Yeah, actually now is a good time to bring in maybe some. We have a lot of folks who are kind of very experienced in EMS, and I'm just curious to see if anyone here is seeing the same problem. I know that in Palm Beach County, I see Chief Coyle is on. We just took the time to create an entire video where we brought a surgeon in just to recap and review exactly what you're talking about, Amit. So I don't know if that's you, Chief Coyle, on there, if you want to pop open your microphone and talk about all the education and training that we've done, but if not, Dr. Shah can continue.
Peter, Wayne Lee.
Yeah. Oh, hey, go ahead, Dr. Lee.
I didn't want to interrupt Charlie. I couldn't tell if he's coming on or not.
Doesn't look like it.
I guess my question to you is, in Broward County, our trauma agency, we review our cases on a regular basis and have been for a long time. To my knowledge, and I've been around for a while, I've never had the trauma agency come back to me and say that the needle decompression was a problem, to my knowledge. So I'm sort of puzzled with you said that essentially only 30% of them, plus or minus, were correct. I would have thought I would have heard from them before now.
Yeah, and there's certainly regional variation, not only in provider experience, but also how these results are tracked. What I'm citing is just the published literature. And most places I go and talk to people, they are aware of at least one incidence of a misplaced needle and a needle ending up intra-abdominally. Most commonly, it's intra-abdominal, but oftentimes it's medial to the midclavicular line. and causing injury. Now, the question is, right, if you look at the fraction of misplaced needles or you look at all misplaced needles and then ask the question, what fraction of them caused injury, right? So the study that I presented earlier, I think it was maybe somewhere between 5 and 10% of the needles caused injury, but like 75% of the needles were incorrectly placed. So I guess the question is, are you tracking injury, or are you tracking appropriate needle placement in terms of laterally anterior to midclavicular line, third to fifth, and anteriorly second intercostal space midclavicular line? So that's the first question. Are you tracking just injury, or are you tracking needle placement accuracy overall?
And Dr. Lee, maybe a good idea would be I can ping the trauma coordinators. I know Candace, Madonna in the Palm Beach area, and I can ping a few of those people and maybe get back to the group next week to see if indeed they are seeing that. Maybe the surgeons would know more, but it's something that I can put on the list and get back to you on.
Yeah, I think that'd be worth knowing. I'm not suggesting that maybe it hasn't happened and I wasn't aware of it. Just that it's never, been a topic of conversation to any degree that I'm aware of. Anyway, thanks, Peter.
Yeah, and thank you
got
for
it.
that.
All right, thanks. You got it, Dr. Shah. Go ahead. Thank you.
I just actually wanted to respond to something, Peter, that you said about training. And obviously, training is critical. But if there were, and this is kind of the thesis behind the device design, if there were a procedural aid that could help you in the moment so that you weren't sort of scrambling to identify appropriate landmarks on, let's say, an obese patient in the moment, and in sort of the heat of the moment, the idea was that could be a nice sort of augment to training that was happening otherwise. So it wouldn't be in place of the training, but it would be in addition to. So when we went into this, we thought, okay, if we can create an adult template and a universal adult template that really leveraged and referenced the patient's own surface anatomical landmarks to identify a safe zone for needle decompression, we would have a solution that would be worth bringing to market, especially if we could create one that was durable and inexpensive and lightweight and really was easily paired with decompression needles. So the image that you see here is from the British Thoracic Society. I think they called it zone of safety. And again, it's a lot easier when you have a thin young man, as is pictured here. A lot of these landmarks become obscured as you leave that specific patient population. What we did a few years ago now is looked at a database of anthropometric data. The Department of Defense, and I believe it was Army specifically, had studied about 5,000 men and 3,500 women and collected 132 measurements on these men and women. Among them were height, axillary height, as is shown here, and chest height. And we use this data to create not only the device, but also the safe zone that's shown here. And again, the thought was, if we could reference the patient's own anatomical landmarks, we could create a universal device. So the thought was we would design it based on that data and then begin to study it and see if it actually worked across a diverse patient population. So the instructions for the device use are actually on the device itself. And you'll see here how it references the patient's anatomical landmark. So the first step is to push the device into the axilla with the arm abducted to maybe 30 to 45 degrees and push it as far up as it'll go. It does have some rigidity in that plane, the plane in which you're pushing it into, so that it can displace fat, and it was specifically designed for that purpose. So you're displacing the soft tissues and pushing the device into the axilla and pointing it towards the iliac crest. And in doing so, you'll have identified some landmarks. So the anterior edge of the device is the anterior axillary line. The mid-axillary line is referenced as well. So you're between those two lines, and between the third and fifth intercostal space, as is shown here by these red dotted lines in the image. Next, you palpate, and so now we're at step 3. You palpate within that safe window to feel an intercostal space, and then place your needle where you feel the intercostal space. Now, if 2 intercostal spaces are identified, we generally recommend that you select the upper intercostal space. And if you can't feel the intercostal space because of excessive soft tissue, recommending that you place the needle sort of in the middle of the safe zone. And then if you feel a rib, just redirect just above the rib. Or so if you run into a rib with the needle, you redirect just above the rib. But again, all of this is printed directly on the device for ease of use. It's a 4-step process. We've designed it to be useful on either side of the chest, and it's clearly labeled right and left. We've also designed it to have the rigidity to displace soft tissue, but also be flexible to conform to the chest wall, so that you're actually holding it up against the chest wall with your non-dominant hand, and then palpating and inserting the needle with your dominant hand. So yeah, once we had the design down, we figured, okay, we have to see if this works. And what we did, and then published in Journal of Trauma, is looked at 12 different cadavers, male and female, 4'11" to 6'7", 80 pounds to 350 pounds, BMI 16 to 42. So the specimens included specimens with shoulder disarticulation, rib fractures, and the idea was we'd place the needles using the device and shoot x-rays in a couple different views and have an independent radiologist tell us where the needles ended up. And this is what we found. Every one of the needles was in the 3rd, 4th, or 5th intercostal space, which is in line with recommendations. And all but one of them were between the anterior and mid-axillary lines. And you'll see the one that wasn't was 2 centimeters anterior to the anterior axillary line. So basically, universal, appropriate needle placement. Again, as defined by that anterior to mid-axillary line, 3rd, 4th, or 5th intercostal space. We had done and presented at the Special Operations Medical Association Scientific Assembly. We had done a user study with a total of 10 paramedic students and paramedics, gave them about 3.5 minutes of instruction, and did 4 standardized patients. Now, this wasn't image guided like the cadaver study, but we essentially had these same users identify both freehand and with a Thorasite the appropriate site for lateral needle decompression. And we found a 50% improvement in accuracy when the Thorasite was used. So 62% to 95%. 100% of the users said they would use the Thorasite if it was available. It increased their confidence by 34%, and there was no increase in procedure duration. So that was the other thing we were worried about, is that, hey, if we introduce a device into this process, it would lengthen the procedure, and that could become a problem, and we did not find that. In terms of ongoing studies, the biggest one is out of Milwaukee County EMS. So it's the city and a few other agencies where medical direction is provided by Medical College of Wisconsin, about 550, I believe, ALS providers. It's a pre and post design. So they're almost done collecting data in the pre data set where before Thorasite was introduced, just your usual palpation approach. I think the first data point they collected was a needle that ended up in the liver. they're in the next week or two gonna roll out training for Thorasite for those 500 plus ALS providers, and then they'll collect data on the post Thorasite launch group to see to assess the accuracy. What's interesting about this study is they have roped in the Medical College of Wisconsin ER, trauma surgeons, radiology, the medical examiner, the local medical examiner, to capture as many of these data points as possible. So it's a very cool study design. A lot of efforts been put into it, and we're excited to see the results there. There's another study out of UCSF, which I don't have as much data on. And again, these are both independent studies. I don't know what they're doing at UCSF, but I believe that it's a similar sort of real world study of the device. So let me just stop there. I wanted to kind of make it short and sweet and leave the rest of the time open for discussion, and see what thoughts you had.
So Dr. Shah, thank you so much. That last slide that you just showed, I think really will answer a lot of our questions. And I'd be curious to see the pre-data just as much as I would like to see the post data. I think that would answer some of what Dr. Lee was getting at. Do you know if on the pre, what exactly are they looking at for those patients who had it kind of the freehand method? How are they evaluating placement? How are they evaluating injury, etc.?
Yeah, it's imaging. So the patients that end up in the ER, I think the majority of them are getting CAT scans. So it's needle placement based on CAT scans. So it's not only, was an injury observed, but also was the needle placed in an appropriate location. And then medical examiner, I believe it's dissection. I don't know whether they're doing any imaging of the patients that end up in the medical examiner's office, but either way, it's pretty definitive. It's either imaging based or through dissection.
Okay, great. And then there are some agencies on this call, including one of mine, where we do finger thoracostomy. Is this device suitable for that procedure as well?
Yeah, I mean, it's a aid to help site a lateral thoracostomy, whether it's a needle, a finger, or a tube. So I would say that you're identifying the relevant landmarks for any one of those procedures with this device. So yes, whether you're placing a needle or using a scalpel, it's going to put you in the right place.
Awesome. I appreciate that one. I'm not sure if we have any surgeons on this call here, but what do the surgeons think about this? And are you seeing any adoption at the hospital level with the surgeons who don't have an ego? I know they don't have an ego, but what do they think about a device to help them get the spot right?
As you can imagine, our first sort of market that we want to address is not going to be the surgeons, right? Try to convince a trauma surgeon that they need help in identifying the lateral site for either a needle or chest tube. That's a pretty big ask. Now, if we think back a few years, it would have been a big ask to have surgeons using an ultrasound for placing a central line or an arterial line, or an anesthesiologist to use video laryngoscopy, or anybody to use an eye. You get the point I'm getting at. So we address first, I think, those that. What are we asking of these guys in the field? To perform an emergency procedure in the hardest possible circumstances with very little assistance. They're given a needle and told to, hey, remember your training. And listen, I'm all for training, but any level of assistance beyond that is helpful. Now, what I imagine will happen is that in addition to this device being paired with needles, I think it may be incorporated in other procedural trays. And at each one of these institutions that I've worked at, not only has this been something we've seen from EMS, but junior surgeons, emergency physicians in training, placing a chest tube in the abdomen, I've seen at every institution that I've worked at. So I can imagine trainees or less experienced providers, even in hospital, benefiting from a device like this. But yeah, the trauma
Great answer.
surgeons,
Okay.
I'm not gonna
Yeah.
hold
Yeah.
my breath for those guys.
Yeah. There's a lot of really smart people on this call, and I want to see if any of them have any questions for you. I mean, I think all of us are data driven, and knowing that there's an EMS study out there at an institution that we know, and we know the people at that institution, and they'll be on our next call actually with Dr. Pepe, who is. Are you Dr. Viper today, Paul? Is that, you're on mute.
So I was originally going for Irma Vep, but I didn't want to take that for whatever reasons. That's vampire. It's a thing. So I stuck with Viper. It's pretty good. But yeah, let's discuss the next call because I've got to switch over to it at this point in time. Did you get the CME code out to everybody, by the way?
Yes, I did. It's in the chat, and it is 15265. Thank you.
125. Okay, thanks. But I'll get back to you later. That's okay. Okay. So just got to move.
Yeah, absolutely. I see anybody else on the call? I know there's a lot of people who have a lot of experience on this call. Anyone want to raise your hand or just put a comment in the chat? Let me ask the obvious question. Amit, do you know what Sam is selling this for?
I think it's about $15 a pop. At least that's what they've got listed on their website. Now, whether there's, I'm really not on that side of things, so I would just direct you to our contacts at Sam Medical. You can feel free to email me. I didn't include my email address on here, but I will put it in the chat. You can email me and I'll connect you with the folks at Sam Medical. I did want to show all the references in case anybody's interested in looking at any of these papers. There's a number of them.
Okay, here we go. Oh, I see some questions. Dr. Daya, okay, answered the question. Yeah, Dr. Jameson is asking, what do some of the medics on this call think of this? So we got to hear from our folks in the street. Let me bring in Brett Cross. You're a ground medic and you're an air medic. Thoughts on this, Brett? Come on, you can.
Hey, good morning, Peter. Can you hear me? Yeah.
Yep.
I think it's a good idea. I had a similar question to you when you asked about the finger thoracostomy assessment that we do as well. I appreciate the research. I think I would like to see one, feel one, and see how it works in real life. When you're down next to a patient. It is one more thing, I guess, too. That's my first thought. It's one more thing. But if it's one more thing that's helpful, it could work.
Yeah, I guess it comes down to, do you feel like it could improve, right? If you feel like your providers sort of universally are getting it right with either anterior or lateral, I can see why this would not be something you want to introduce, right? It is one more thing. But if you feel like there's room for improvement, and especially given the price point that Sam has placed it at, it seems like we try to make it an easy thing to adopt, not only from the procedure standpoint and incorporation, making it an easy device to use, but also from the price.
Right. Okay. Awesome. Let me see. David, Bill, and Rebecca, you're being called out by your medical directors. So let's get one of you to unmute and talk. In the meantime, Andrew says, our medics seem surprised when I tell them how often the tubes are not positioned in the pleural, the needles are not positioned in the pleural space. Providing more entry site consistency will be helpful. Dr. Daya says, what's the shelf life on this?
That's a good question. It's measured in years, I'm sure, somewhere between 3 and 5. But I can get back to you on that. I'm pretty sure Sam would have that listed on their website. but I'll let you know. So the thing is, because they're also looking for military adoption, they've got to have, so DoD has some standards in terms of the products they adopt, and I'm pretty sure 5 years is what DoD generally wants. Let me take a look and see if I can find that just while we're on this call.
Okay. All right. We have another minute or two left. Would love to hear from one of the other street folks.
Hey, Dr.
Brett, go
Anthony,
ahead.
this is Brett again. Can I ask 2 more questions?
Sure.
One question I have is, how's it stored? And 2, do you have any idea how people are storing? That's not bag space and where it goes, and if it's flat, those are all things that also have a role in whether or not you stock it, right? Do you know what?
Can you guys, I'm going to stop sharing so that you can see my camera a little bit easier. And I'll just show you one of these devices. Can you guys see me okay?
Yeah.
This is the device in terms of flat.
Oh, okay.
It's
Yeah.
basic paper thin. Okay. Bendable. It's weather resistant. And I think they tested it to some ridiculous, again, they test for military standards. So like super hot and super cold. But I can get you, and actually they have listed on their website because I've seen it before. I can get you the exact temperatures, but they're anticipating like cold weather and desert usage. So I don't think it's.
Does this thing stick to the patient, Amit, or is it there's no stick to it? You hold it, you do the procedure, and then you remove it.
Exactly. They also designed in this perforation thing if you want to cut it. I find it easiest to just place it, feel, and then do my needle decompression, move on, take it off.
Got it.
So, but yeah, in terms of, I don't think shelf life or temperature / weather is going to be an issue, but I'm happy to give you more detail on that.
Awesome. All right. Well, listen, we're at the bottom of the hour. I always, I have a soft place in my heart for people who go out there and do things, but do things in a way that's evidence-based, and you've clearly done that. Here's a quick question. Reusable, and you say one-time use. Okay,
but for training, right? Like if you're training people on it, like you can use it over and over again for training purposes.
Right. Well, excellent. Well, I'm going to put your email out there so people can contact you and learn more about it if that's the case. We appreciate you taking your time to do this, and we also will, sure, reach out to those people who are doing the study. But to me, this seems like a pretty, it adds one layer of safety, and we have so many new medics, and the staff turnover is so high from many agencies that something like this could be a simple fix. So thank you for being an innovator and for
appreciate your time, guys. I really do. And
yeah,
please feel free. The guys at MCW that are running the study and they're actually now in the midst of training. They're going to have a lot of great experience to share. So get the word from them. Do they like it? What do their medics think? How did incorporation go for them? And of course, once we have data, we'll be able to publish, or they'll be able to publish.
Perfect. Excellent. All right, Amit, thank you so much. This will be on record. I'll get you the recording. And we now have another webinar that Dr. Jamieson is going to take us over to. You're welcome to stay, but you don't have to. And I'm going to pop over to the other side. So thank you so much, Amit, for coming on today.
Thanks, guys.
Right. Appreciate it, everyone. Yep.